Hello, I'm James Huff. I am a student at the California Southern University in the psychology program. Today I'm going to give a brief presentation on borderline personality disorder, which is one of the conditions that we studied during the course. I'm going to give a general overview of some of the data, focus a little bit on suicide risks, share some assessment approaches, and then briefly cover some therapy approaches as well. Borderline personality disorder is one of the most common disorders that we encounter in practice. It has distinctive characteristics that result in severe functional limitations, and the expression of symptoms actually can fit the National Institute of Mental Health's definition of serious mental illness. Several sources, including SAMHSA, provided that information. So a shift there in reference to traditional ways of looking and treating personality disorders to the consideration that the expression of these symptoms with borderline personality disorder can actually fit the characteristic of a serious mental illness. The prevalence is estimated to be 2% of the general population. 10% of inpatient populations are known to have borderline personality disorder. And the characteristics of borderline personality disorder increases the risk of suicidality. Now, the author of our text gave us some data in reference to suicidality. In my additional research, I found a research study from the National Epidemiologic Survey. This was done in 2013, and it was a multivariable adjusted logistic regression study. It had a number of participants up to 36,309, with most of those meeting the 5 criteria for borderline personality disorder. And what they found was there was a lifetime prevalence of suicide attempts of over 30% in that population. And that is comparing to 3.7% that we see that participate in that without borderline personality disorder. The one thing that they did find was an indicator of suicidality in borderline personality disorder is the chronic feelings of emptiness. And so the results of the research shows us that we should be assessing for chronic feelings of emptiness routinely when we're working with our clients with borderline personality disorder. The DSM-5 has 5 or 9 characteristics making up borderline personality disorder. In order to get an official diagnosis from the DSM-5, a client needs to be positive for 5 of the criteria. Those include fear of abandonment, unstable relationships, unstable self-image, impulsivity, self-harming and threatening suicide behaviors that are repetitive, emotional instability, mood swings, angry outbursts, chronic feelings of emptiness, mood dysregulation, and dissociative experience, loss of time, and episodes of paranoia. Other common characteristics include splitting of self and others, and the tendency to idealize and then degradation when they are working with others. SAMHSA has some really good information out on their website in reference to borderline personality disorder, and there's a few things they would like us to recognize. Once again, that the expression of the symptoms can meet the severity of a serious mental illness. And many individuals with borderline personality disorder may have developed symptoms because of, as a way to cope for childhood trauma. But they also wanted to note that not all individuals that can meet the criteria for borderline personality disorder actually have that history of childhood trauma. The symptoms do overlap with other conditions. Bipolar, post-traumatic stress disorder is a couple that they've noted. One important thing is that the condition should no longer be considered chronic. And I think that's the traditional way that we've looked at personality disorders, that they were fixed and rigid. SAMHSA wants to recognize that borderline personality disorder actually does respond to appropriate treatment and may have a good long-term prognosis. Experiencing a symptom remission is something that can occur with a borderline personality disorder. Old data shows that it's mostly women who have borderline personality disorder. This is now controversial considering to SAMHSA. which indicates that there's more data that shows that there's no real gender difference in borderline personality disorder. In reference to assessment, Medline lists the revised diagnostic interview for borderline personality disorder as the gold standard in reference to assessing borderline personality disorder. That's quite a large assessment of up to 97 items. I did find another assessment tool. And this comes from the Manual of Dynamic Deconstructive Psychotherapy. That's one of the psychotherapy approaches that Ray introduced us to in his book. There are a lot of assessments items that basically go along with what we are familiar with in reference to the APA guidelines in assessing. Some of the things that they do add that coincide with the symptoms of borderline personality disorder include major, how a client copes with major coping and defensive mechanisms. They've also added impulsive behaviors, of course, addiction and addictive behaviors, including using the cage screening when there's alcohol use involved. Occupational and legal history, as well as specific types of relationships with family and friends, closeness of those, how they resolve conflicts. And they actually add a couple performance cognitive tests for the borderline personality disorder assessment. Of course, those cognitive tests are basically designed to see if a client is a good candidate for their approach, the dynamic deconstructive psychotherapy. All right. So psychotherapy approaches. I think we've all seen the workbooks from Dr. Marcia Lanaheim in reference to the dialectical behavioral therapy. That is one that has been pretty renowned. Even Ray says that there are numerous studies that support DBT's effectiveness, including reducing suicide and increasing positive changes. It's an approach that combines cognitive behavioral therapy with Buddhist mindfulness principles. It targets the complexity of symptoms in borderline personality, emotional regulation, internal and external splitting, sense of self and self-esteem and self-clarity, and suicidality and self-harming. It is very structured. Not everyone is comfortable with that and can feel a little bit overwhelmed. It is more intensive in therapy. The dynamic deconstructive psychotherapy was mentioned as Ray as a possible therapy approach where you have someone that might be more sensitive to intensive therapy approach. It's a very interesting approach. It's very complex. It draws from a number of psychotherapy theories and old techniques. So something to look up. And again, they do have their manual online that's easily accessed. It's the Manual of Dynamic Deconstructive Psychotherapy. So something that I'm excited about and something I'll definitely continue to be looking into. So in summary, borderline personality disorder can have symptoms presentation that meet serious mental illness, high risk of functional limitations, including suicide, no longer considered a chronic and can improve the prognosis with treatment. And it's no longer known to be just an untreatable condition. There are several established evidence-based approaches to helping with borderline personality, including the dialectical behavioral therapy. As clinicians, identifying challenges in therapy is important. We should plan for these with interventions, such as we know that there might be some ruptures in the therapeutic alliance. There might be a lot of transference when working with borderline personality disorder. But if we do plan for those and we intervene well, they can use that experience with the therapist and take it out to outside relationships with them. So in ending, the research required to complete this course definitely gave additional insights into recognizing the seriousness of borderline personality disorders. It also introduced treatment approaches that warrant additional consideration in adapting to clinical practice. All right, thank you very much.